Changi General Hospital, Singapore, and also affiliates to the Duke National Medical School. As a clinical professor, he has a few papers in his field in well-recognized medical journals. And now, time is yours, Professor Yan.
Thank you for the kind introduction. I'm Dr. YY here from Singapore. Xin Chao. I'd like to thank the organizers for inviting me, and I'll be speaking on cryoablation in the MSK system. Some technical glitch right here.
Due to the technical problem, so do you mind waiting for a few minutes for the technician to resolve the problem? Sorry about that. Just a few minutes, please. Yeah. Sorry about that. Okay, so during the times of waiting time, so we either anyone to raise the questions for Dr. Tunitif? Okay, yes, please. Bạn có thể chuyển mic cho okay, yeah.
Nick. Okay, thank you for sharing us nice information about osteoblast ablation. So I'm an interventional radiologist. I came from Mongolia, and I had some cases of osteoblast. It's interesting thing is my first case done in Kazakhstan, and I use the same technique. So you mentioned about I never do again osteoblast ablation near the vertebral spinal cord, right? So how about if you have like an electrode with a thermoreceptor? Nowadays, currently we're using the electrodes which have thermoreceptors, like a fixed one and a variable one, moving the thermal thermosensor, I mean, yes. How about if you have thermosensor electrode, will you do like near the vertebral area? I just want to ask this.
Okay. If in the retrospect, if I was again, there again. So I will use, but I not just only use the thermal detector. I also use like air epidurography or cool technique. I, I think is maybe the technique is make me like comfortable to do. At that time, it's very much pressure because of like this very near the White House sector, and his mom is also a doctor too, so it's very. So, but I think the thermal monitoring, the temperature monitoring is very useful in other side too, especially at the peripheral. Sometimes that is close to the nerve. I think it's very useful. Yeah.
Okay, thank you. And nowadays we have the many different of the kind of the radio frequency generators exist, and we have impedance mode and we have temperature mode one, and also that you mentioned about don't consider about the impedance, because temperature is more important for this bone osteoderma, right?
Yeah.
That's why that we're gonna use that temperature mode.
Yes.
Am I right?
Yes.
Okay.
Yes, you're right.
Yeah. Okay. Thank you.
Because of the bone lesion is usually have high impedance. So if you have to just only monitor in temperature. Yeah.
Okay. So what do you think about that bone vertebral body vertebral nerve denervation, BVN? Do you do also similar like osteoma? And for the BVN, do you do BVN?
No.
No. Okay.
Sorry.
Okay. Thank you.
Okay, thank you for your question. Then we will leave another question to the end of next talk. So now, Professor Jan, back to stage and deliver his presentation. Thank you.
Right, thank you for waiting. So sorry about it. There was some technical glitch, no videos here. Okay, so Xin Chao, I'm Wai here from Singapore. Thank the organizers for inviting me for giving this talk on cryoablation in MSK system. So I'll be talking about the indication, patient selection criteria, technique and effectiveness, thermal ablation, and complications. So for those who do not know about cryoablation, so we have a cryoprobe that generates an ice ball. The boundary of the ice ball denotes the 0 degrees Celsius zone, and at 0 degrees Celsius, encoder, extracellular ice and intracellular ice starts forming. At negative 20 degrees Celsius, apoptosis starts occurring, and negative 40 degrees Celsius is the necrosis zone. So that's the Q zone. As you can see on the left-hand corner, the electron microscopy. At negative 1 degree Celsius, metabolic uncoupling, cellular acidosis, ionic imbalance, cytoskeletal disassembly starts occurring. And at negative 4 to negative 19 degrees Celsius, you start seeing the extracellular and intracellular ice formation. You start getting shrinkage of the cell, as well as tissue shearing. So these are the available cryoprobes in the commercial market. The most well-known is definitely that by Galil Medical. They come in different shapes and sizes. And the one below is by IceCure. The difference is one uses pressurized argon to generate ice ball via a Joule-Thomson effect, while the other uses liquid nitrogen. Another key difference is that the Galil Medical probes has the ability of active TOR, which is quite useful in an MSK system because sometimes after cryoablation you want to inject cement. Cryoablation is different from other ablation modalities, as possesses many advantages. You can monitor the ice ball on CT, as well on ultrasound. The disadvantage of ultrasound is, as you can see from the ultrasound monitor, is structures deep to the ice ball cannot be assessed. There's also the abscopal effect, rare but useful, seen in lung, kidney, melanoma, and breast cancers, whereby an immune mediated reaction is incited after cell death through the activation of T cells from the release of intracellular contents. This results in cell death distant to the ablation site. There's also an analgesic effect. Cryoablation is less painful. You might just escape with conscious sedation and LA instead of GA. Cryoablation has the ability to destroy large tumor volumes as opposed to RFA. So when do you use ablation? You can use it for both palliative and curative intents. In benign lesions, as very comprehensively detailed by Dr. Pramod, such as osteostomas, as seen in this picture, osteoblastomas as well, and chondroblastoma. It's also useful in malignant bone tumors, most commonly and most well-known in bone metastasis, also in myeloma, as well as in primary sarcomatous tumors such as osteosarcoma, chondrosarcoma, and chordomas. These are reserved for the anatomically unfavorable, patients not suitable for surgery, or recurrent sarcomas. So when do you employ ablation in bone metastasis? You can use it for local tumor control. You can use it for tumor debulking to reduce pain, or when the tumor is encroaching upon critical structures such as your major vessels and nerves. You want to improve the quality of consolidation after cryoablation when you inject cement to reduce cement leakage and improve cement fill. When you want to decrease the risk of secondary fracture in a bone tumor, some institutions advocating a 4 centimeter size for that. Also, there's also a decreased chance of tumor seeding in the needle tract. So in the NCCN guidelines for adult cancer pain, latest in 2024, ablation can be performed to reduce pain or prevent skeletal-related events, such as fracture, the need for surgery, the need for radiation therapy, or cord compression. You can also perform bone tumor ablation to reduce the dose of opioids. For example, if the opioids dose are maxed out or there's intolerable side effects from the opioids. A recent prospective trial in the MOTION trial demonstrated the rapid and durable effect of cryoablation in bone metastasis. In this trial, patients had a 2-point score release, a 2-point score decrease at week 1, and persistent at week 8, and continued to increase for the rest of the months, as well as improved quality of life. So how do you decide which patient is for cryoablation? Usually go through a multidisciplinary board consisting of a radiation oncologist, a medical oncologist, and an orthopedic oncology surgeon. You go through different factors. You want to know the type of metastasis. Is this metastasis radiosensitive? What are the features of the lesion? Where is the lesion sited? What is the treatment available in your hospital? Is this lesion for curative or palliative intent? What is the estimated life expectancy? What are the pain characteristics? And your patient's functional status. So in cryoablation, very commonly performed with osteoplasty, the whole idea between curative and palliative intent is really just to decrease pain and improve function. Curative intent is used for also oligometastatic disease or oligoprogressive disease. In a study by Deschamps in 2014, of which 122 bone metastases, 48 treated by cryoablation, increased success was seen in metachronous bone metastasis, the absence of a bone erosion, a lesion size of less than 2 centimeters, and the absence of any critical neurological structures in the vicinity. 1-year overall survival rates were 91% for the oligometastatic disease group, 90% for the long life expectancy group. And the bone disease-free survival was 64% 1 year after the ablation. So what are your considerations? The patients have to present with a focal pain, usually more than 4.10. Have a reasonable amount of life expectancy, about 3 to 6 months. Some say 1 month. Whatever the case, who are we to stop the patient for trading for a better quality of life? Also, lesions less than 1 centimeter from critical structures may be excluded. You also want to know the patient's functional status. You don't really want to perform complex treatment for patients with low life expectancy or poor functional status. If the patient is wheelchair-bound or bed-bound, you don't want to do a cryoablation with cementoplasty and screw. You can just escape with just cementoplasty to decrease pain, for example. You want to set realistic expectations. You have to tell the patient, your pain may not go away totally. However, the pain will be markedly reduced. If it's in a weight-bearing bone, the patient will be able to walk. Maximum pain effect is usually seen within 2 weeks. So this is an example of how you treat a soft tissue tumor, in this case a desmoid tumor. You pierce the tumor usually through ultrasound, with the assistance of ultrasound. You hydrodissect to prevent the ice ball from reaching the skin. And usually it's about less than 1 centimeter from any critical structures that you try to hydrodissect or pneumodissect. If it's near the spinal cord, you do some neural monitoring. You can put a warm glove at the skin to heat it up. And you want the ice ball to overlap completely with the tumor for curative intent, or just destroy the intended portions of the tumor if it's debulking intent. If you use multiple probes, you can place them about 1 to 2 centimeters apart. And for cryoablation, you can put up to 20 probes. So this is an animation of how you could perform a cryoablation of a bone mets in your acetabulum. You first have an access needle using a needle guidance software. Then you put the cryoprobe in via a coaxial method. Retract the needle so that you don't get any skin burns. Ice ball starts forming and gets larger. And you want to target the tumor and bone interface. Just be careful in the pelvis. If the ice ball reaches the joint, that's when you get complications, such as joint effusion, osteonecrosis, synovitis, chondrolysis. After that, you may or may not want to inject cement. And on your cement, you monitor it on orthogonal fluoroscopic views. And there's a tumor-sedative effect of the cement of about 3 mm. And this is what you get. Injection should be stopped immediately if you see cement leakage, obviously, in the vessels. So this is a patient who with metastatic urothelial cancer to the sacrum, whom I performed cryoablation, and followed by cementoplasty with subsequent resolution of the low back pain, sustained for about 6 months. So cryoablation has been shown to be effective in multiple studies on malignant bone and soft tissue tumors. I would just like to highlight for the sacrocoldomas, the progression-free survival is about 36.8 months, and the pain score drops from 7.3 to 4.2. It's also very useful in osteoblastoma, although I must say RFA is still one of the most established, but there's emerging evidence and abundant evidence of cryoablation as well in osteoblastomas. In a study by Meng, the cryoablation group spent significantly lesser time in the hospital as compared to surgery. Both groups showed notable improvement in the pain scores. Also, for cryoablation, you do not have to pierce or skewer the nidus. You can just place an ice ball and let it overlap with the nidus. Also, you might not need GA. You could escape with sedation and LA, but that depends on the patient. So if you have a proximal femur osteoblastoma, like what I did in this case, you can externally rotate your femur so that you do not involve your femoral neurovascular bundles. Cryoablation has been shown to be useful in other tumors as well, such as osteoblastoma. However, in osteoblastoma, as it's very frequently near the spinal cord, you need to apply a lot of thermal protection measures. In bone cysts, in aneurysmal bone cysts as well, you also can use cryoablation, and they all have reasonable success rates. In soft tissue tumors, cryoablation can be used, usually described in case reports, or small studies, such as leiomyosarcoma, rhabdomyosarcoma, liposarcoma, endometriosis of the abdominal wall, synovial sarcoma, as well as peripheral nerve sheath tumors. A lot of them are just alternative to surgical resection. LIPA and all described in 2014 a criteria for patients eligible for cryoablation. And that criteria consisted of tumors located deeply, size of less than 5 centimeters, high aggressiveness, as well as a diagnosis of dedifferentiated mixed liposarcoma or mix of fibrosarcoma. There's abundant literature in desmoid tumor cryoablation as well. In the NCCN guidelines for desmoid tumor, patients can undergo an initial period of observation in the absence of progressive, morbid, or symptomatic disease. In the case of progressive disease, you could still observe if the patient is not very symptomatic or the location of the tumor is not critical. However, intervention is recommended for patients who exhibit ongoing progression and morbidity and significant symptoms. So in this flow chart, you can see that cryoablation is used for abdominal wall, truncal extremity, as well as head and neck locations. In a systematic review by Fora, it has shown that this decreased symptoms, improved quality of life, low complication rate, as well as a durable short to medium term tumor response and symptom relief. Cryoablation is comparable to current frontline or alternative therapies, with a non-progressive disease rate of 85.8%. The curative role of cryoablation remains promising. In a study by Olo, they said that more long-term data is required, but in that study, they achieved a curative rate of 68.4%. Cryoablation has a role in vascular malformations as well, usually in venous malformation or fibroadipose vascular anomalies. It's used as a first-line treatment or second-line treatment after sclerotherapy. In a systematic review by Fish, 55 lesions, there was a mean decrease in lesion size of 92%, a mean decrease in pain score of 77%, complete resolution symptoms in 63.6%, and improvements in 94.5%. And they only experienced two major adverse effects of about 3.7%, of which patients experienced persistent dysesthesia. This was a case of a venous malformation that I ablated in the elbow, which I will show you a follow-up imaging after. So we'll move on to cryoneurolysis. So why cryoneurolysis? Because cryoablation does not disrupt the epineurum or the perineurum. So there's a lower chance of neuroma formation as compared to other thermal ablations or even surgical resection. The whole idea of cryoneurolysis is to induce a Sunderland 2 injury so that you get reasonable amount of pain relief with subsequent regeneration, as your axons regenerate at a rate of 1 to 2 mm per day. Cryoneurolysis also results in a longer pain relief as compared to pain injections. It can be performed in an outpatient setting under sedation or OA, and the whole idea is to include the nerve within an ablation zone. Varying freeze-thaw cycles have been described, as low as a single 122nd degree freeze to as much as repeated cycles of 10 minutes freeze cycles. What kind of freeze-thaw cycles you use depends on the size of the nerve and the composition of the nerve, because a bigger nerve will require longer freeze cycles. Also to note, if your nerve is a motor nerve, it's a general contraindication to cryoneurolysis. However, if a patient has a terminal illness, then again, cryoneurolysis may still be indicated after all. These are the possible target sites for the nerve that you can use cryoneurolysis. In my practice, the more common ones are intercostal nerve, where you can place your cryoprobe at the intended level, as well as one level above and one level below, preferably sited 5 centimeters from the exit foramen to prevent vascular injury. Morton's neuroma can also be treated with cryoneurolysis. And this was a case done by my friends in Vancouver, from the Vancouver Bone Squad. In this case, you employ a 120-second freeze cycle, and once the ice ball touches the bone cortex or encroaches onto the subcutaneous fat, that's when you stop the ice ball from growing. This was a case, interesting case of a bone metastasis to the left iliac wing, of which patient presented with a left lateral femoral cutaneous nerve kind of pain that was resistant to phenol injection as well as RFA of the lateral femoral cutaneous nerve at the iguanal ligament level. So patient subsequently came for cryoablation, and we ablated it and generated an ice ball large enough to cover the intra-pelvic course of the lateral femoral cutaneous nerve. Patient was subsequently able to wean off his ketamine infusion. So when attempting pelvic cryoablation or ablation for the matter, it's important to know your anatomy of your relevant nerves. In this case, the lateral femoral cutaneous nerve, other nerves that may not be relevant to you, ilioinguinal, iliohypogastric, as well as the genital femoral nerves. And this was the result. This was a case of a schwannoma that I ablated in your left gluteal region. It's tiny. The gold standard still remains surgical resection. However, there are case reports that says that cryoablation can be performed as an alternative therapy. Reason being, not all patients are for surgery. Not all patients are fit for surgery. And sometimes when so tiny and so deep, the surgeon doesn't want to operate. Also, some patients may also experience cosmetically disfiguring surgery because of its deep location. So ablation might be the better option sometimes. So when you're performing ablation, you want to always use protection. Protection, protection. All right. You can do it by passive or active. Passive will be a patient feedback. You can put a thermocouple or through neuromonitoring. If it's a neuromonitoring, it's usually for spinal lesions. And if you're intending to use it, I suggest you tell your anesthetist way beforehand, because some anesthesia agents can interfere with your neuromonitoring. For example, your inhalational anesthetic agents can prolong your latency of your somatosensory evoked potentials, and this might confound its interpretation. Active measures include hydrodissection, pneumodissection as well. So what are the common side effects of cryoablation? You can get pain, discomfort, which you can treat with paracetamol, bruising, swelling, numbness of less than 2 weeks. As the ice ball melts, you get a watery discharge. If you cryoablate bone tumors, you have a secondary fracture rate of 1.2%. Depending on its location, you can get varying kind of side effects as well. It can involve the skin, causing skin necrosis, nerves, vessels, joints such as osteonecrosis, synovitis. If it's in the pelvis, beware of the bowel and major nerves. If it's in the spine, beware of the spinal cord or nerves. In this case, I just want to highlight in skin necrosis, because it was a large tumor, even though there was skin warming, but because the ice ball was so huge, after the procedure, they did not continue to warm the skin. And as the ice ball was still melting, the skin was persistently subjected to a 0 degrees Celsius temperature, and this resulted in skin necrosis. So the key here is to always put a warm glove over your ablation site, even after the procedure has ended. So this was the elbow venous malformation case that I ablated, who presented subsequently with synovitis and joint effusion, and was unable to play golf after that, and she was quite sad. But the key here is this was mistaken as rheumatoid arthritis by the subsequent radiologist. So it's always important to know what kind of procedures your patient has been to before the scan. This is another case of a desmoid tumor cryoablation. In this case, we can see that there's this enhancement in your greater trochanter that was mistook for local recurrence. But actually, if you see the CT, this is actually due to the ice ball ablation zone encroaching into the greater trochanter that was misinterpreted as local recurrence. So again, you want to know what was done and where was the ice ball placed. So with that, I'd like to thank you all. You've been a wonderful audience. I would love to see you in Singapore in September, where we have lots of oncological interventional topics. Thank you so much.
Thank you very much for your very comprehensive talk, and please remain in the stage for us to give our certificate of appreciation. And Dr. Keung, please.